which may be bright red. After that, I think you know, in the stomach we have hydrochloric acid. What reaction? Reaction is acidic. About respiratory tract, it is alkaline reaction, like this. No, and I said before what sputum usually forming, that forming can contain bubbles of the air, like this. For bleeding from upper part of GI tract is typical some sign. It is melena. Melena you will not see immediately after onset of the bleeding. In average in 24 hours after onset, because melena it is black dairy stool, black dairy feces. So it is different. Oh, plus what you should know. If it is vomiting, it can contain pieces of the food. I think it is the main differences. After that, I will tell, like in short, about every complaint. I will try to explain everything during today's lecture. I'm about subjective and objective examination. I will try. So about pain, only the main information. Like I said before, we have pain receptors only in the pleura. So if pleura is affected, in this case we have pleural pain. And in some situations, who has maybe strong cough, it is not maybe muscular pain, due to like overstaining of some muscles like this. It is a little bit different. If it is affection of the pleura, here this slide you can see diseases which are accompanied by dry oxidative pleurisy. In future you will study it is the when I think in one lecture about syndromes, you will study like different causes for different syndromes of thickening of the pleura, fluid accumulation in the pleural cavity like this. So I will not repeat, you can read by yourself. And what are the main characteristics of pleural pain? Because patient can feel chest pain not only due to pleural infection, because the chest region, it may be direct injury, so trauma, it may be due to inflammation of intercostal nerves, for example, or muscles affection, like inflammation of the muscles, how you wish. It may be, if to consider chest pain, not only pleural pain. Chest pain may be due to heart problems that you heard and we will study in future. It may be due to like GI tract problems. So we have many. But what are the main characteristics of pleural pain? Pleural pain usually localized in the chest, usually in lower part, in lower part of the chest, like this. And like I said before, this pain usually increases during deep breathing, coughing, and changing of position. But what position? If affected site is known, patient prefers to assume position on affected site. Affected site, I think you explained before, because pleural, we have two layers. Usually, movements of the pleura like each other, it is absolutely painless because we have some amount of the fluid. In some situations, due to inflammation, it will be painful, because we have pain receptors here. And what you should understand, more amplitude of movements, more pain. If patients to restrict, to decrease pain. So during inflammation to I think healthy side, patient can feel more pain, but when we'll assume position on the affected side, it will the pain will be relieved, decreased like this. Yeah, and what is here is written? Pain is not only so sharp, so sharp. It may be like aching pain. In some situations, like dull pain. In some, maybe like it is acute character, but characteristics may be different. Very intensive, like sudden, sharp pain, maybe in case of pneumothorax, if it is spontaneous pneumothorax, if it is accumulation of air in pleural cavity, it can develop suddenly, so it is sudden appearance of the pain. It is very sharp, intensive pain. Next of the complaints, it is dyspnea. What is this? What patients can feel? Patients feel shortness of breath, like disorders of the breathing, and this condition can be accompanied by disorders of rate, rhythm, and depth of respiration. Sometimes somebody can feel like difficult inspiration or difficult expiration. According to classification, dyspnea may be physiological, pathological, subjective, objective mixed, inspired, respiratory mixed. What does it mean? If to take physiological and pathological dyspnea, physiologically, I think everyone had it during the doing of some exercises. Exercises, I think your physical education, like this. So we have, it is normally to have this physiological dyspnea because we have tachypnea, increasing of the respiratory rate, like this. And about pathological, you will be explained a little bit later. What does mean subjective, objective, and mixed? The term medical subjective. It is what patient that can tell about his disease, his problem. That subjective, just like from the patient's words, like this. And so patient feels difficulty in breathing, but doctor doesn't see any changes in the rate, depth, rhythm of respiration, nothing. As example, like hysteria, it may be. Patient feels, but you cannot see anything. Objective, it is when the doctor can estimate by objective method. That's all. Maybe after counting of respiratory rate, like maybe tachy or bradypnea, depth, maybe superficial respiration, or maybe like deep really, or just what I will explain a little bit later. So it is objective, but usually the patient has like both, like mixed, can feel, and doctor can be detected by some objective examinations like this. And we have according to what is the difficult inspiration or expiration, or it may be both, we have different causes of inspired dyspnea. Look, about inspiration, one of the mechanisms of what are the causes? It is when difficult to lung tissue to be extended, to be extended. When we have something, for example, accumulation of fluid, air in pleural cavity, it may be due to like fibrothorax. The lungs cannot be extended properly, and when we have something, some obstruction of upper airways, in this case, it will be really inspired dyspnea. This moment very important. I would like to tell about some of my experience, but I'm afraid we have restricted time, because once my patient was hospitalized with diagnosis COPD, but COPD we know, no, but you don't know, you will study only. When patient has expired dyspnea, patient, according to his words, he cannot properly, inspiration was difficult for him. And I thought how it may be. I examined, I thought about why, and usually we do computer tomography only in some cases, because earlier when I worked in the department, it was not so widespread to send patient, and we had only one, I think, CT scan like this, and we sent the patient, and it was cancer in upper part of trachea. So it really was inspired because couldn't inhale like this. It is very important moment to know what kind, and for your future patients to ask what kind of dyspnea. After that, about expired dyspnea. respiratory is so typical for COPD bronchial asthma. During the expiratory phase, we have it is like expiratory collapse of the small airways, and expiration is prolonged and difficult. The examples I have already said, that is bronchial asthma, COPD, like this. No, and some situations it may be mixed. About dyspnea, that we said it may be physiological, maybe pathological dyspnea. I hope you remember your physiology lessons. And we have about mechanisms of the breathing. At first, air should pass into the airways. After that, we have gas and air exchange. We have it is diffusion and perfusion of gases. That is so certain blood supply. And we have breathing center. So we have different types, different causes of dyspnea appearance. At first, it may be centrogenic. It is not only due to respiratory problems. Centrogenic, it may be due to, like you can see, humoral effects. Maybe you heard who has fever. As far as I remember, every degree of Celsius plus 4 respiratory movements like this that we have. So it is dyspnea really, or maybe when we have like hypercapnia, here written about carbon dioxide level, and like other diseases. So centrogenic we have, and due to some respiratory problems. Here you can enumerate any, restriction, gastriction, resection, inflammation, different types of the respiratory problems. I will not enumerate it. And here written, reducing the exposure of lung tissue, difficulty straightening of the lung, variation of the chest mobility. So we have really many. And it may be not only due to, it may be due to disease of the blood perfusion. For example, in case of pulmonary edema, it may, in case of pulmonary embolism, patient can have dyspnea due to anemia. So really many causes. We have something like different. It is not so different. We have dyspnea and we have suffocation. Here written about stridor, as far as I see, because it's not I cannot see like everything on my slides. About stridor. So when we have something in upper airways, it is like barrier or compression by tumor, by goiter, or maybe something artificial what will pass into airways. Stridor, it is noisy, loud breathing, what you can hear from distance. It is stridor. And we have suffocation. Suffocation, it is like here written, that is pronounced sudden dyspnea. It is, we can compare with asphyxia. Patient cannot breathe at all. We have different reasons for suffocation appearance. I think you heard about bronchial asthma, acute pulmonary edema. Here, different types of dyspnea also will be classified by different types. That may be spasm of vocal cords. It may be spontaneous pneumothorax. So it may be accompanied by only dyspnea, maybe suffocation. And about pulmonary embolism, it depends on, so what patient will have, only dyspnea or suffocation? It depends on, I think, size of the branches, what will be closed. If it is small branches, patient will have only dyspnea. If it is big branches of the pulmonary artery, can have suffocation. So it is different degree. We can consider like different degree of dyspnea, a little bit, or it is like compare with asphyxia, like this. Now let's pass to objective examination. I think I finished with subjective examination. It is enough, and during the lessons you can consider maybe in more detail some moments objective examination. Objective examination includes what are the main goals of objective examination. You can any objective examination includes inspection, palpation, percussion, auscultation. Today I will try to explain everything, and next lecture will be about lung auscultation. So what about palpation, walls? At first, we usually assess form of the chest. Then we can assess symmetry of the chest, if presence any deformations, equality of expansion of both half the chest and respiration, or condition of intercostal spaces like this. We can check type of respiration, we can count respiratory rate. Visually, we can assess respiratory rhythm, depth of respiration, and we can measure surface of the chest like this. So it is the main goals of the palpation. At first, I said we will assess form of the chest. Form of the chest, I think you all explained before, the similar with types of constitution. We have normal-sthenic, asthenic, and hypersthenic. It's for healthy process. We have like healthy, and we have pathological forms of the chest. About healthy, what are the main criteria of the, what points do we usually use to assess certain type of the chest, certain form of the chest? It is angle between neck and shoulder, it is condition of suprainfraclavicular fossa, and I usually explain how to. Don't forget about something, you should start from top and explain to bottom, or to continue to bottom. We have angle between neck and shoulder, suprainfraclavicular fossa. We have Ludovici angle. What is Ludovici angle? It's angle between the manubrium and sternum. It is level of the second rib, but it is sternum. After that, epigastric angle, what you can check. After that, important direction of ribs in the lateral part of the chest, width of metatarsal spaces in comparison with width of the ribs. You should and the position of the scapula. And last is it is anterior, posterior, and lateral ratio. And if to describe every type of every form of the chest quickly, quickly I will do it. So with analogy with types of constitution, we have, but we use different points of assessment. Don't forget about this. So if patient has asthenic type of form of the chest, just sorry, it is high. The normal-sthenic, that is around that. It is normal-sthenic because I don't see upper part. So normal-sthenic form of the chest, unweighted neck and shoulder, usually around the 110 degrees. We have moderately apparent supra and infraclavicular fossa, distinct Ludovici angle, epigastric angle. Usually epigastric angle, I think I will demonstrate later picture, but the same how to check equality of expansion. Usually we place our thumbs on the level of the costal arch, like this, so and connect it near the whole process. To see costal arch, you can ask patient to pull belly inside or breathe in, and costal arch will be detectable. So you will place your thumbs where and connect near the whole process. You can see angle. So if it is 90 degree less or more, in case of normal-sthenic form of the chest, it is 90 degree. After that, if patient has normal-sthenic form of the chest, the direction of ribs in lateral part of the chest usually moderately oblique. If to compare width of ribs and intercostal spaces, usually equal, ribs and the width of intercostal spaces to scapula are closely fit to the chest. And if to consider ratio between anterior, anterior, posterior, and lateral, ratio, it is usually 2:3, like this. It is main characteristics of normal-sthenic form of the chest. Now, it is asthenic form of the chest. What? Angle within neck and shoulder, usually more than, more than 110. Distinct and pronounced supra and infraclavicular fossa. Ludovici angle you cannot detect because the sternum is flat, absolutely flat, like this. Epigastric angle usually acute, less than 90 degree. We have, if normal-sthenic, it is moderately oblique direction of the ribs and lateral part of the chest. Here it is almost vertical direction. Intercostal spaces usually are wide in comparison with ribs, and scapula don't fit to the chest closely, and ratio and lateral is 1:2. The chest looks narrowed. Hypersthenic type of the chest, form of the chest. Angle of the neck and shoulder is less, when 110. The suprainfraclavicular fossa may be smooth, maybe a little bit like protruded, distinct with which angle, epigastric angle usually more than 90 degree, and ribs nearly horizontal. Scapulas are closely fit to the chest, like similar to the masteric of the chest, and ratio and lateral is 3 to 4. We have many pathological types of the chest. I will try to explain a little bit about this. The a paralytic form of the chest, paralytic or paralytic form of the chest. This type of the chest typical for some cachectic patients. So I hope you remember what is a cachexy. Not only that, typical for tuberculosis, cancer, Marfan disease as a genetic disease. What are the main characteristics? You can read here written many things. The paralytic form of the chest look like asthenic and has characteristics of asthenic form of the chest. What is the difference? It is usually asymmetrical. It is asymmetrical position of the clavicle. It is asymmetrical location of like what I don't know what name about supra in intraclavicular fossa. It is like look like different. One maybe a little bit more retracted, one is less, like this. So it is asymmetrical really. We can see atrophy of muscles like this. About other characteristics, absolutely same, similar with asthenic form of the chest like this, but asymmetrical. Next, we have emphysematous form of the chest, emphysematous worried form of the chest. Maybe you heard. We have the main reason it is COPD, chronic obstructive disease, and emphysema itself, because it is emphysematous form of the chest. Emphysematous form of the chest, if to describe in short, look like hypersthenic form of the chest. But what is the difference? The suprainfraclavicular fossa maybe like smooth, maybe like protruded a little bit, and look, pay attention to width of metatarsal spaces. If you remember description of the hypersthenic form of the chest, where written the intercostal spaces are narrowed in comparison with ribs. Here, what you can see, intercostal spaces are wide. Sorry, I cannot change here. I wanted to correct it. So the spaces are wide, so it is different. Plus anterior-posterior size, it is barrel shape, double shapes, because this dimensions like 1:1 ratio, like nearly 1:1 ratio. After that, we have it is like pigeon form of the chest, form of the chest. So it is typical for rickets. And what are the main characteristics of this type of the chest? It is like increased in anterior posterior direction, because it is like compressed from like both sides, like this. And sometimes in some situations we have rib cartilages, what can be detectable like thickening of rib cartilages like near the sternum. So it can be detectable if it is it was in childhood, but in adults, if somebody had before, in adults you will not feel it like this, but you can see this demonstration. Now after that, we have some some like funnel, funnel chest. What is this? It is due to patient can have any type, like signs, asthenic, non-asthenic, hypersthenic form of the chest, but in addition, we have like fossa, compression in a lower part of the chest, like this. Sometimes it may be idiopathic, sometimes you can see it is like lower form of the chest. We have some occupation due to this. So maybe absolutely normal only with compression, And we have in the form of the chest, this scaphoid form of the chest. So the main cause of this form it is syringomyelia, and in comparison with previous, we have compression in like in upper and middle part of the sternum, the upper and middle part of the chest. So previous, it was in lower part here, in upper and middle part, but syringomyelia, it is serious health problem. Sorry. And now we have some types of deformed chests. Because you studied that maybe due to deformation of the spinal cord. Spinal cord deformation, we have different like curvatures, like to right or left side, that is scoliosis, or maybe if this curvature to back, like increased the physiological thoracic kyphosis. In this case, it will be like humpback, and vice versa, maybe curvature forward. So it is. It will be like asymmetrical. So pathological forms due to asymmetry, and due to deformations of the spinal cord, like this. Next. I don't see upper part. It is very bad. The volume of the chest that changes. Okay. It is next what we should check by inspection. In some body, so changes of volume. So some half of the chest can be increased in volume or decreased in volume. It may be temporary, maybe like constantly. When temporary, when we have some acute conditions, you can see here hydrothorax, pneumothorax. Hydrothorax, it is accumulation of fluid in pleural cavity. Pneumothorax is air accumulation. The both conditions will be treated, and so air and fluid will be removed. So after that, I think patient will have like normal volume of the chest wall. And about constant, you can see pulmonectomy. So after resection of some part of the lung, you cannot return it. And pulmonary fibrosis, unfortunately, any fibrosis, there is no any like treatment, any medications which can like release or which can like solubilize like this fibrosis. So in this case, patient will have for a long period of time changes increase and decrease volume of the chest. When you can see it, you have already explained about this. So if it is increased volume, we have accumulation of fluid here. If fluid may be transudate, exudate, what is this? You will study in future. It is different causes. Pneumothorax, it is accumulation of fluid, pneumothorax in pleural cavity. And if it is compensatory emphysema, we have like vicarious lung when if it was, we have affection of the one lung, maybe whole lung, like this, and another will take function of affected lung. So, and in some period of time becomes like the vicarious emphysema develops, and emphysema, it is hyperiness of lung tissue, so the one half of the chest will be increased in size like this. Now about other reasons, about problems with abdominal cavity, the accumulation of air, like fluid in abdominal cavity, only we have expansion in lower part of the chest. When can be decreased in volume, very important word. Again, pulmonary fibrosis. So when we have lung collapse, it may be due to obstructive epilectasis. After obstruction, we have collapse of the lung, for example, or it may be due to fibrosis itself. Pulmonectomy, I think it is understandable. And pleural adhesions, when we have some after maybe inflammation of the pleura, so it is adhesions, and I think it is if it is significant, it can be decreased, like a little bit compressed, decreased in size, but not so. I think in comparison with other reasons for this. After that, that is lagging of what we can check. One more thing. It is equality of expansion for both half of the chest in respiration. As a rule, how to check this? I think I have information. The next slide, I'm about picture. But who has any unilateral process? If it is unilateral process, you will see lagging. So you will check like equality of expansion. If it is unilateral process, because you can see here how to check it. Usually on the anterior and posterior surface. Anterior surface you can check it visually, or in addition, like palpation of epigastric angle. You can see here, I said before, what forms, like it is on the costal arch and like tips near the xiphoid process, like this. So like this, you will check epigastric angle, like how many degrees, and also you can assess equality of expansion. After application of your hands, you will ask patient to breathe deep, and you will compare movements of your hands. Like it will be simultaneously, or maybe some of your hand will lag in respiration. We can do it on the anterior surface, and we can check on the posterior surface. Posterior surface, like you can see here, we usually apply our hands by the same manner, and it is level of the 10 ribs, level of the 10 ribs. Do the same, ask patient to breathe deep and compare movements of your hands. We have one more, the same posterior surface. We can place 2 fingers below anguloscapula, and we can ask patient to breathe deep. And after that, again, you will compare the movements of your fingers. I said that if you want, you can read after that. This lecture will be, I will put it on Moodle again. You will be able to watch some period of time.